Okay. So we have a very nice way by which you can create a discharge summary when the patient gets admitted through an LLM or NLM algorithm that as the patient comes to the hospital, the discharge summary already starts to get made.
Oh, nice.
And then every progress note gets updated or any medication change comes into the discharge summary. So by the time the patient is ready to go, the whole thing is already done.
Oh,
So
wow.
nobody has to like summarize the whole thing
So
again
it's an LLM that's running in the background
on our EMR.
of the EMR.
Yeah.
And the EMR is
Epic.
Epic.
Yeah.
And the LLM was built as an
Ev-
add-on
yes.
for Epic.
Epic, yeah. Through Mayo.
But not deployed through Epic,
No,
deployed
through Mayo. Yeah.
So
Yeah.
yeah, that's really great.
Yeah. No, we have I mean, our current chair of cardiology, Dr. Paul Friedman, I think he's a complete visionary. I mean, I've never seen a person who is just thinks like 25 years ahead of the curve. And he was the one who came up with this AI ECG backed by one of our phenomenal AI engineers, Zaki Atia. And these guys came up with some incredible algorithms, like how from a normal rhythm ECG you can predict low ejection fraction, risk of atrial fibrillation, risk of aortic stenosis, amyloid, hypertrophic cardiomyopathy, and all these things. And my personal interest in this is that because I run our ECG lab now, so we have an ECG dashboard, meaning that whoever gets an ECG gets that ECG comes on this dashboard, and there are at least 15 algorithms running at one point on every ECG which has been done today and historically, which will give you an AI output of low EF or risk of cirrhosis, aortic stenosis, diastolic dysfunction, potassium now, pulmonary hypertension, and several things, and more in
Across
the
the
works
hospital, like in a
across. Yeah.
24-hour period, all EKGs done in the hospital.
No, no, forever. Even if the patient got an ECG 1991, you would still get that.
So then, like, what do you do with that once you?
So
who's
right now it is
interpreting
mostly
that?
for research purpose.
Okay.
Only one algorithm is FDA approved, which is for low ejection fraction. So there was a study which one of my colleagues led, called as the Eagle study, where they looked at several thousands of ECGs who get done, and then from the AI ECG algorithm for low EF, can you predict low EF? And the AUC was about zero point 0.9 or a little bit more than that. So that's phenomenal, because if you know the patient is having low EF, then at least an echo can be done even if the patient is asymptomatic. And actually the more interesting part was, even if the ECG is false positive, meaning the AI tells you that it is low EF but the echo does not, in few years the EF actually goes down in a lot of these patients.
Oh,
So it can almost be like a marker of a
It's
marker.
predictive,
Yeah,
yeah.
yeah. So it's pretty nice.
It is. Wow.
And if you look at the AUC for say pap smear, stress test, mammogram, that's like zero point 0.8 around that. But this one is like about 0.9 and a little bit more. And it's only going to keep on getting
Getting
better.
better.
Yeah.
Yeah. Wow.
That is really, really interesting right now. One very simple use case scenario, what is one of the bane of existence of physicians is insurance company denying approvals for a test or for a medicine or, for whatever reason. But if there is a way or something can be built in the EMR to know whether when you order a test, what are the odds of it getting approved right away, so that what are the odds of it getting approved right away, or if there is going to be a challenge, and if there is going to be a challenge, can an automatic appeal letter can be generated at the same time. So if it gets denied, the letter goes in right away and then you're done. So those kind of things, I think AI type models would work out really nicely. Another
Yeah.
thing is that if you prescribe a medicine and patient picks up the medicine, and if you prescribe anticoagulant or something like that, there are so many of them available. You order X medicine, but the insurance doesn't approve the X medicine, it might approve the Y medicine. But even instead of the patient calling all these people, why not it just comes through this one algorithm where it only tells you, well, this is going to get approved, yes or no. If yes, if no, what's the alternative, and where is probably the cheapest place where the patient can get it, so that patient can go there, get it, and move on in life. Because
So,
I think those kind of places where AI can be very helpful.
so I think we're now moving from AI that existed pre-LLMs and pre-large language models to this generative AI kind of use cases. A big concern remains that there's hallucination and there's lack of grounding in factual data.
Yeah.
How do we even address
Yeah.
that? Because without the data available
Yeah.
in the systems, and especially software engineers like me, I'm not a doctor by any means, but like as an AI person, when I'm trying to fine tune models, when I'm trying to build or let's say prompt a LLM to talk about these things, there's just very few data
Yeah.
available.
So I think there are a couple of ways you can look at it. One is kind of a 30,000 feet view, and one is kind of a kind of boots on the ground kind of an outlook towards that. So if you look at a 30,000 feet view, no two patients with pneumonia are the same. No two patients with stroke are the same. Every patient is unique. And all the algorithms right now are doing a very good pattern recognition job without going to differentiate how one person is going to respond to a particular treatment versus the other person. That's where I think AI is may go there in few years, but right now I think that should still be taken care of by the care provider at the bedside.
Of course.
But at the bedside, where AI can be helpful is some of the things what we talked about: access to medicine, access to future appointments, or if you look at one of the highest cost of healthcare right now is rehospitalization. You admit somebody. I mean, you might have seen so many times that you see somebody in the ER comes in with COPD or asthma exacerbation. You give some medicine, they go home, they come back again in few days again. So how can we prevent that rehospitalization or repeat visit to the emergency room? Is there a predictors what we can look at beyond standard logistic regression type models and see if we can identify that? And taking a step forward, whether any variables that a patient uses at home can pick up these signals, so you can prevent that trip to the ER and then just get triaged at home itself, and therapy can be modified. And some incredible work has been done, I know, in heart failure type things. From voice you can pick up if somebody has fluid overload or is in AFib or something like that. I think that could be the future where AI can play a really, really good role.
Yeah, I agree. I think in the area of remote patient monitoring, as you're referring to, the bio data that you can collect in between the acute care and the post-acute care setting, which I think we're all familiar with the fact that readmissions are the highest cost to the healthcare system right now. So yeah, I think there's a lot of work to be done. There's a lot of great work that's been done even in patients that have what we consider outpatient illnesses that we can treat, pneumonia, say, their progression to sepsis, right?
Absolutely.
There's a very clear pathway that progression occurs by, and these are not very mysterious or tailored per patient. It's generally easily
Picked
picked
up.
up with predictive data. So I
Yeah.
think there's a great use case scenario for that
Yeah.
coming up.
Another thing where I think AI can play a major role is to assess compliance of therapy. You give 5 heart failure drugs to a patient still comes back. Is there a way you can figure out what's going on at home without invading the privacy to see if they're actually compliant with medications, or if there is dietary indiscretion which is causing all these things. So I think that's where I think AI can play a role. So I don't think AI can teach a care provider how to treat a patient, but AI can be smart that how it can enhance the experience for the care provider in providing even better care than what is being given right now.
And at home, especially if if you're sick and you really don't know what you don't know, perhaps AI, and especially a generative AI and LLMs, can help you demystify what terminologies doctors are using, what you need to do, and how much do you need to comply, how do you need to comply, and so on. Because like there's so many questions. What does this mean? What does that mean? And I feel like LLMs can help elucidate, if not specifically train the people at home, patients at home, and at least make it easier for the patients to understand what their at-home care looks like post-discharge, so that
Yeah.
hopefully they don't have to go back into the
Yeah,
ER.
a simple thing would be, if you have a 20-minute follow-up with a patient, and if you're an internal medicine doctor, there are 15 problem lists to deal with, and there is no way a good internist can figure out everything in 20 minutes. But if it just gives some prompts in that visit, and maybe one of these algorithm can expand on these things at home, so the patient can sit in the comfort of their homes and listen to it. I think those are the kind of things which might be helpful.
Yeah, and even things that, like you mentioned, education in layman's terms, right? A lot of times, what we tell patients and what they hear, especially when you're really sick inside the hospital, in the few minutes that you're being discharged, can be hard to remember a week or two out. And those are the use case scenarios I think you're referring to, where it's translated in a way that's easily understandable and packageable and repeatedly reinforced 1 week, 2 weeks, 3 weeks out, which, as we know, is the reason that people typically come back, is because of non-compliance in the immediate post-discharge setting, or difficulty with following some of the instructions in the immediate post-discharge setting.
And maybe there's some room for the care provider to come into play here as well, because the care provider at home is maybe a family member or somebody who's helping them out, and you know they would be more they would find this more helpful because they weren't probably in the conversations with the doctor, but they are now providing care, and so somewhat of the demystifying of like what's going on would be
Yeah, I mean, I
helpful.
think that will be very nice if it works out, but there are also several issues and layers to that, you know. Number one, how would they interpret that information, HIPAA compliance, whether, you know, health data confidentiality, there's always some role in that. But I think beyond that, if we can just simplify a doctor-patient encounter to a patient so that they can go back and revisit. It's like watching a YouTube film, right? If you like it, you pause it, you go back, you look at it again and again and
Exactly.
again. And then so that the person doesn't have to go and see a provider so many times, but at least they can revisit that experience at home. I think those are the kind of things where it might be helpful. I think it could be very, very helpful in patients who deal with, or providers who deal with a lot of mental health, because it is impossible to sort out somebody's mental health issues in 30-minute clinic visit. But if you can have a consistent feedback to that patient through one of these things, I think those are the kind of things which will make a big difference.
Yeah, and I think to your point, I would say anecdotally, it takes about 3 to 5 repetitions of mentioning something, especially in these complex diagnoses, before a patient is even able to generate the questions that they have, or what they have thought about it and how it fits into their lives, and what barriers they find in their lives to follow some of the instructions that are given. So to your point, I think having kind of a YouTube video type model where you're referring to it and re-referring to it, and say you have a 2-week or 4-week follow-up already set up, you can come to that in a more informed and prepared way, ready to make a more tailored treatment plan for you, as opposed to fragmented
Right.
questioning. And then the other thing that reminds me of in terms of fragmented, I kind of see AI as filling in sort of as the glue in the system, and I deal in the acute care space, in the emergency space, and so a big barrier and challenge for us is we deal with incredibly fragmented care. Sometimes a patient will come in where their records are at a different health system across the street, but they've chosen to come to seek emergency care at one place because that's where they're traveling to, or that was what was nearby, and we have limited access to records. And oftentimes we spend a good number of our resources trying to churn through those records, trying to understand what has been done, what needs to be done. And this doesn't seem like a problem that necessarily requires a high level of expertise. It's more of a collating of data from different fragmented, siloed parts of the healthcare system, which I feel is a very large role that AI can play in coming up with that data and tailoring it for that patient encounter on that particular visit, the pertinent data.
No, absolutely. I think fragmentation of care is huge. If you just look at heart failure hospitalizations, if you are discharged from a hospital and you go back to the same hospital, the outcomes are very different than if you go to a different hospital. And we had published on it a few years back, and so those are the kind of things. If you can avoid that, that's how you're going to reduce a lot of costs in healthcare, and then prevent over testing and over diagnostics, and at least then everybody knows what's going on with a patient. I think those are the kind of things which hopefully these type of interventions may improve.
Yeah, there's a YouTube celebrity called Dr. Mike, and I was listening to one of his videos where one of the things came up was about like how do we personalize medicine, right? Because obviously you need statistical significance to have policies and have medicine for the entire population, but then maybe there are some abilities to kind of use AI to identify how do you do that population categorization, maybe personalize some of that healthcare. What do you guys think?
Yeah, I think personalized medicine and precision medicine is here to stay. How one person is going to respond to a treatment is going to be very different than how the other person is going to respond. And a lot of times it's going to be beyond p-value. There's so many other variables which are involved in that. And maybe AI can play a role in that, but a lot of times it's also common sense approach at bedside which will do the trick. but hopefully AI can enhance that common sense. So I think that's the whole notion that AI is going to replace a provider, that should go away. AI should be there to help a provider and help a patient would be the way going forward.
Yeah, I think like in general, when there's been like doctors and healthcare providers talking about AI. There's AI practitioners such as myself talking about healthcare, and there still seems to be that almost dichotomous like separation of we don't talk to each other so much. And obviously at universities, there's like been or health centers such as yourself, there's been like good collaboration there. But for the general people, when I visit hackathons, when I'm visiting this, like people are working on healthcare, mental health, for example, like you were saying, but they just don't have access to the right physicians in there, in the startups or in the things. And I think the challenge right now for AI to impact healthcare is not necessarily the lack of the technology not being able to do it. It's probably the data and then the people not talking to each other.
So data is gold and data is oil, and data is much more than that now. Data is currency. So that is always going to be a challenge. And healthcare is a little bit unique than ordering a pizza, because everybody's health information is so private and personal to them that it is hard to share it. And even if it is de-identified and people share it, it is not always anonymous, because if you have an unusual disease, so there are only 50 of them in a town, and all 50 people know each other, you cannot really anonymize or de-identify that kind of data. So it's going to take some time, or there should be a better partnership between industry and people who have the medical data.
And I think this also speaks to, historically, I think academia and physicians, providers function in a silo at the bedside with patient care, and industry functions to innovate. And it's now gotten more common that that there's more. We're good. That there's more collaboration, but it kind of speaks more also to the business case scenario for making sure that there are providers at the table that are driving some of these decisions. What we don't want is a reiteration of some of the earlier phases of EMR, which were developed in silos separate from providers and technologists, and what we had was a difficulty in adoption because of, or maybe multiple streams of adoption, because there was not a collaborative effort between multiple stakeholders. And I think this kind of speaks to the additional business case to be made, even in these startup settings where capital is difficult to come by, for having providers at the table and creating some of these initial decisions and being a part of some of these initial decisions.
I think the way I look at these things is, when we are seeing a patient, we are not thinking about profit. But when a venture capitalist or a startup company is thinking of their own idea or tool algorithm, they are obviously thinking of improving the existing landscape, but they're also thinking about profit. So I think if we remove that profit angle and just try to see initially if we can make something work better, I think that is going to be the key, because I don't think healthcare is going to change by a new invention or a tool. It's going to be changed by an idea.
Right.
And that and like a lot of other things which have happened in our lifetime, which was an idea which clicked and made it big. So I think that's where it has to just have a it should just fit in well that both the stakeholders are on the right page to make these things happen.
Yeah.
So I think a lot of the companies, medical AI companies, should not come in medicine to make profit. They should come to medicine with the aim of helping patients, which is the aim of the care providers, nurses, doctors, everybody. And then in that, if something nice comes about, then everybody's happy that way.
Yeah, and I think to your point as well, sometimes we also have these very well-meaning small enterprises working in silos that can't get funded and can't scale. And so it even more behooves us to start at the very beginning with an idea for the pipeline and the capital in mind, with the understanding that maybe we're going to break even or just do something better and iterate better, and maybe not end up in a large profit margin, but at least iterate better and change lives in the process. So.
Absolutely, yeah. Like, at Mayo Clinic, we have a thing that the needs of the patients come first. That should still be the motto of all these AI companies who want to be part of medicine, that still the needs of the patient should come first, and then the rest of the things can, follow.
What do you feel are some of the major roadblocks, at least from the 30,000 foot view of
Yeah.
where we stand right now?
I think the language what everybody speaks is very different, because what the AI engineer speaks, there is no way a physician is going to understand that, and what the physician's actual problem at bedside is, I don't think the AI engineer is getting it at this point. And there are very few unique people who have an engineering background who go into medicine, or there will be some aberration who went into medicine and then went into engineering. So it's hard to find that one person who knows it all. So I think as long as there is a language or communication where everybody understands the use case scenarios and how things can improve or impact each other's domain, I think that would be the way going forward.
Yeah, personally, there's a couple of ideas that I'd worked on in healthcare, and I thought like immersion was the best way for me to understand what's going on. Because like at that, for those for those projects, I came in more as an operations person, trying to identify in a clinic setting, like where outside the doctor's room are the process challenges of like and asking a patient what their healthcare information is for insurance and all of that stuff, right? And so I think for me personally, having that sort of access meant that I'm able to understand those bottlenecks, but also see in person what's going on. And this was in a setting where there was a large number of patients visiting the doctor as a pediatrician, and it became like a almost great. The doctor's inside, obviously treating the patients, and there's a deluge of, let's say, kids when flu season's on, and something has to just improve the process. And maybe AI was not hot back then, and we were thinking about more software as an experience. But I think definitely to that end, immersion would help. Is one thing that I've personally found would help engineers understand the medical experience for sure.
Nice. So, you live in Palo Alto and in California, which is the hub of all the innovation and everything else. And, you're at the cutting edge of, all around you is all this conversation which goes around. So, as a physician and a care provider in the trenches, where do you think AI in medicine or healthcare will go in next 3 to 5 years? And is it just a hype or optimism, or do you think this is really going to change the way we treat our patients?
I think AI is here to stay. I don't think it's a hype or over optimism. I think that the lens with which we look at AI and how we're going to use it may need to change. I don't believe it's here to replace physicians or the general work that we do in taking care of patients. Medicine will always be a one-to-one human interaction, in my opinion. But I do think that there is a lot of work that we do in medicine today that is mainly administrative, mainly not related to direct patient care. And that's where AI has the largest scope for making large changes. So yes, I mean, I think it will change the way we treat patients, because when you free up time to deliver care at the bedside, it often is that time is spent at the bedside. And I think the data correlates with that as well, that when there's more time freed up in the day, it directly feeds back into being at the bedside with the patient. So that, I think the experience of AI for a patient the experience of healthcare for a patient will change with AI. Based on how we start using it in our daily operational workflows.
And I actually appreciate your optimism, but I've been doing this for a while. That initially in my training we used to have paper charts, so at least we had more time with the patient. Our handwriting was terrible. At least we would scribble something and we would move on. But then as EMR came by, so much time gets spent in making that note to have a billing code for that. That if you go to a clinic or if you yourself go to see a provider, I would say 70% of the time that person is looking at the computer and not looking at the patient. And I think that's where I think your point is very well taken, that if some of this work of the charting or all the non-medicine thing what we do is taken care of, putting in an order. Why do we have to type every order we have to put in? It should just be automatically, not through an order set, but somebody should just pick up on what we are thinking and do these things. I think that's where hopefully these things will get better.
Yeah, and voice recognition to that
Yeah.
point as well. There shouldn't be a reason to sit there and type every single order. I think a big part of why we're also so into charting is the legality behind it, the malpractice behind it, trying to have a record of what actually took place. And if we can change some of the perceptions around that and have a more transparent, real time record of what's happening, then maybe we'll get away from trying to be so controlling of the chart and just do what we need to do in order to help out the primary complaint that the patient's there for, you know?
So I think if you just want to sum it up, I think AI is here to stay. I don't think there's any escape from that. It is not going to be as what you see in some movies, that there is going to be a demon to harm anybody. But as long as we can mutually coexist, it will be good. But I think really the future is that people who don't use AI will be replaced by people who use AI. It's not that if AI is going to replace it, it is just from our physician perspective, people who don't use AI will be replaced by people who use AI. And with aging population and all the other things what we have, I really think this is a tremendous opportunity in healthcare, where if we can partner with the AI engineers or AI infrastructure, we as physicians would get better at doing what we do. Our patients would get better care, and hopefully we can reduce costs and just reduce the overall healthcare burden, which is immense on our economy right now.
Yeah, I think that's really well said. There's a lot of promise for the future. We have some big challenges ahead of us, big problems to tackle, but I think with the right lens, we can probably do more good than harm, so to speak.